Welcome to another ERN-ReCONNET webinar. I am Hanna Vieira. I will be the moderator today. I'm a member of the Portuguese League Against Rheumatic Diseases. I come from Portugal. I'm Sjögr Europe co-founder and board member, and last but not least, ERN-ReCONNET Sjögren IPAG and steering committee member. Today, and because it's Sjögren's Awareness Month, we will be putting the spotlight on Sjögren's chronic inflammatory immune-mediated disease, so little known, difficult to diagnose and treat, and even difficult to pronounce. It is also a disease very difficult to understand and even to accept for those around us, our family members, our colleagues, employers, and health professionals as well from different medical specialties. With no further delays, I am pleased to introduce our today's speaker. I'm having a bit of trouble changing my slides. Do you see the second slide with Professor Vasco's name on it? Okay. So Professor Vasco Romao is a rheumatologist at the Rheumatology Service of Hospital Santa Maria, the biggest hospital in Portugal, where he is the coordinator of the Sjögren's multidisciplinary consultation. He is also the coordinator for Sjögren's disease at ERN-ReCONNET since 2017. He is a clinical researcher at the Rheumatology Research Unit of the Molecular Medicine Institute and an assistant professor at the Faculty of Medicine, University of Lisbon. His research focuses on the clinical and pathogenic aspects of Sjögren's and also on the pathobiology of synovial tissue and rheumatoid arthritis. He is the author of over 50 publications and over 160 scientific communications. Before I give him the floor, some notes about today's webinar. It will be recorded and published on the ERN-ReCONNET website and on YouTube. During the webinar, please address your questions in the Q&A box or use the chat, and your questions will be addressed by the speaker after the presentation. I will now stop sharing my screen and welcome Professor Vasco Romao. The floor is yours.
Thank you, Anna. Thank you for the introduction, and good afternoon, everyone. It is a pleasure to be here. Now myself talking. I was here last week moderating Professor Vissing's amazing talk, also on Sjögren. The aim of today's talk is really to highlight the most important and general aspects of Sjögren's. We will not cover everything. It is designed to be a webinar aimed at patients, relatives of patients, co-workers, and also patients and health professionals dealing with that are not so acquainted with this disease, but also have to deal with these patients. And so let's get to it. The plan for today is this. So we'll try to understand what is Sjögren's disease, or what do we call Sjögren's disease? So the controversy already starts here because you're probably more used to saying or hearing Sjögren's syndrome, but this is currently changing. So what are the symptoms of this disease? And is it just dryness, or are there any other consequences? And we'll see about that. And also, how do we diagnose Sjögren? And if we'll also address the question, is there treatment or is there a cure for Sjögren's? And also some guidelines on potential patients, or if you have some of these symptoms or you suspect or you've been diagnosed, what can you do? So we'll start with the story of Venus Williams. So Venus Williams is a very well-known player. She's still active. She started playing when she was 14 professionally. By the age of 17, she reached her first Grand Slam final. And by the age of 20, she won her first Grand Slam. And she was #1 in the world by the age of 21. And so she's also the sister of Serena Williams, who's also a very good player. But Venus is actually older than her and has Sjögrens. And she has been a Sjögren advocate and helped a lot across on the US and also across the world to spread awareness about this disease. And in fact, we can get a glimpse of what is the impact of this diagnosis when we, through the lens of a public figure. And so in 2011, she had been out for 2 months and she was playing the US Open and she quit. And she came out clean and said she had been diagnosed with Sjögren's. And this is more recent news because she's still playing. Imagine having to wear contact lenses for playing tennis and not being able to do so. But we can, it's better if we read what she said at the time. And she says, I was diagnosed with an autoimmune disease called Sjögren syndrome. Before that, I just felt like I could never get into shape and it made me feel lazy because all I ever done is work hard and it was difficult to work hard and I still worked, but it didn't want to work because it felt so bad. And so I would periodically go to the doctor and say, I don't feel well, I can't, I'm constantly exhausted. And that went on for about 7 years before I got too sick. So even a top player that has access to the top doctors went through the desert that many patients recognize before being diagnosed. And she's one, and we'll discuss this. So one of the key symptoms that had a great impact on her was the fatigue, and she was constantly getting tired. And she says that obviously it affected her profession. She couldn't play tennis anymore. She was out of the game, and when that happens, you start going down in the points table. And also, she wanted to play her best tennis, but she couldn't. And she was used to, since a very young age, being at the top, and she just couldn't do that and reach that type of level as she felt at the time. And we can see the impact graphically when she started playing. So this is the top year position in a year in blue, and at the end of each year, so the ranking for the WTA. And so she reached in 2001 to number 1, and then she was diagnosed. And you see that when she was diagnosed, her position fell, but she was able to come back, and we'll see more about that, and even get to top 5. So to get into the top 10 of ATP or WTA ranking is really, really, really hard. And there's really a huge difference to the rest of the players. And she could do this, but we can see here graphically what is the impact of Sjögren's disease. And so where does this name that I think all of us that are not Swedish pronounce wrongly, but it's the way it is. So Henrik Sjögren was an ophthalmologist, and he first had contact with the topic of dry eyes in 29, when he was sent to this part of Sweden, where immigrants that were originally Swedish but had been, and this has a weird parallel to the present situation today, but they had migrated these Swedish people to Ukraine because those territories were taken up by Russia at the time. And this was in the 18th century, 19th century. But then when they were allowed to come back to Sweden, even though they were living for generations in Ukraine, a lot of them had trachoma. Trachoma is an infectious disease of the eye that can cause blindness and destroys goblet cells that produce mucin, and so also causes dry eyes. And so he's seeing a lot of this in these patients, in these people coming back to Sweden. But then it was only when he moved back to Stockholm when he describes, observes and describes a middle-aged lady with reduced tear and salivary and also sweat secretion, and what they call rheumatismus chronicus. And so he published this, and he described for the first time the term keratoconjunctivitis sicca that is still used nowadays. And so he got more and more interested into this, and he moved to another part of Stockholm and defended a PhD thesis called On the Knowledge of Keratoconjunctivitis sicca. And here in his thesis, he describes 19 patients that had these features. So this means that the cornea and also the conjunctiva of the eye were very dry. And this could be identified with specific tests. And out of these 19 patients, 13 of them had arthritis that could be deforming or non-deforming. And in almost all of them, they could demonstrate inflammation, mainly in the conjunctival or lacrimal conjunctival surface, lacrimal glands, and in one case also in the salivary glands. But the jury didn't like his thesis very much. He was very criticized, and he got a mediocre grade, which prevented him from having professorship at the time. But then after this was published and people and physicians across the world started recognizing this condition in their patients, he was accepted and moved back to the academic career. And so this is the story of Sjögren. And so what is actually Sjögren's disease? So it is a chronic immune-mediated disease where there is a dysregulation of the immune system, mainly the adaptive immune system, which is the lymphocytes, B lymphocytes, T lymphocytes, that are very important for the protection and production of antibodies and so on. And this immune system, this regulation leads to the attack of healthy tissues and organs. And this really is a disease that affects the entire body. It is commonly said and stated that and it is, of course, one of the most evident and one of the first symptoms that the targets are the exocrine glands. And this can be the salivary glands, the lacrimal glands, but also sweat glands and other exocrine glands that produce mucus substances for instance, in the trachea, the vaginal, in the case of women. And so we don't really know everything. There's still a lot to understand about the pathogenesis, but it is thought that this chronic inflammatory process in the tissue damages that tissue. And this gives rise to common complaints such as lack of saliva, lack of tears, dry mouth, dry eyes, and a lot of other symptoms that come up with this. But in addition to that, to the severe dryness, Sjögren causes inexplicable, very crippling fatigue, which is inexplicable in terms of we don't understand, the patient cannot explain why he or she is feeling like that, but also for the doctors. We in the Sjögren clinic, we say a lot, I don't know, when the patients ask us, why am I feeling like this? And really, this is still one of the many unmet needs, which is the fatigue. But also chronic pain, musculoskeletal pain, muscle, joint pain, and also full-blown arthritis, which is seen in a large proportion of patients. But also, and as I said, a quite substantial proportion of patients has systemic and major organ involvement. With this is a smaller percentage, but systemic involvement is very common. So this really is a systemic disease. We don't know the cause. As most immune-mediated diseases, usually there's a genetic background, so like a fertile soil, and then environmental factors come into play with this genetic background and determine if this person will develop Sjögren's or not. It's very common that people ask, will my children have this? And the question is, as always, as commonly, we don't know, but it's not a matter only of the genes. The genes are important, but it's between the interaction of genes and the environment that will lead to the development of the disease, but there's still so much to learn about this. Usually it affects women, so 9 out of 10 patients are women, and it can occur at any age, even in children, but most oftenly it presents or starts around 40, 45 years. So the prevalence, and this is kind of controversial, it is not a closed matter yet. Data from Europe have estimated, so the proper prevalence according to specific criteria within the rare disease range. There are other studies suggesting it is a more common disease. There are some problems also with the codification, because only very recently in the last ICD codification is there a code for Sjögr. So this gives us an idea of the importance that the disease has had in the past. And there's still considerable diagnostic delay. It is very common for patients to have symptoms for several years before they get diagnosed. It may be associated with other rheumatic diseases, so patients with lupus, patients with rheumatoid, that also have Sjögr. And sometimes maybe it's the lupus that is, more active, but other times it's Sjögren's and not the RA that is well controlled. What is unquestionable is that it has a great impact on the quality of life of these patients. And this cannot be stressed enough, because often patients complain that they are not well understood by their colleagues, even by their physicians, that this is just some, nuisance, that if they put some teardrops and chew some gum, they will do okay. But this really is not the case. So what are the symptoms? We usually talk about this triad of symptoms of dryness. This can be dry eyes, dry mouth, and this is very heterogeneous. This means that some patients complain a lot, but then when we try to measure, we see a lot of saliva, but they complain a lot of dry eyes. The other way around is also possible. And so it's not a matter only of quantity, but also a matter of quality and which glands are more involved. And we had a great talk last week about this by Professor Vissink. And this also happens with the eyes. And so some patients are very, very symptomatic. Other patients are not so symptomatic, but they can still have the consequence, for instance, of the dry eye. In terms of fatigue, so fatigue really is severe, can be severe. It is hard to explain. Patients don't understand why they feel like this. And it's really very common and very present throughout the course of the disease. And these patients also have pain that is often hard to characterize. So it is not arthritis. The patients can also get arthritis, but it's pain in the joints, in the muscles that comes and goes, and it does not have a specific pattern, but it keeps coming back. Also, up to a third or more of patients also have episodes or have had in the past of mumps or swelling of the parotid glands, the submandibular glands, and these sometimes are diagnosed as infection or salivary or a stone. And then when we do the clinical history, we acknowledge that it was already there in the past, and this may have been the first manifestation of the disease. And so, but is it really just dryness? So Sjögren Europe had a very nice campaign, I think a couple of years ago, where they represented the 15 types of fatigue that patients can have. So it's not, and it's very, we try to narrow it down to how fatigued are you, but it's really complex, and this may be just related to the physical aspects, to concentration, or even just going and coming back to the doctor, or not knowing, or having a flare. And so patients describe very well all these types of fatigue that is really multidimensional. And so because we don't really, it's hard to characterize, and because it is hard to characterize, it is hard to treat and understand. And so this is one of the major, remains one of the major unmet needs in Sjögren's. But not just fatigue. So this really is a disease that affects the whole body. And of course, these symptoms or manifestations vary from patient to patient, but they usually are, they can be from very common complaints like brain fog, which is a feeling of not being able to really focus, having this kind of not thinking clearly, having difficulties concentrating. Also, this is being more and more recognized feature of dysautonomia, so of malfunction or dysfunction of the autonomic nervous system. Patients can have fever, can lose weight, can have night sweats. Of course, they can have all the problems in the eyes. And if they are not careful in hydrating and putting artificial tears, they can get corneal ulcers, infections, and the same for the mouth. And really problems secondary, as we heard last week, problems secondary to the lack of saliva are really common. But as we just shown, so swollen and painful salivary glands, and patients sometimes describe what is that when they are eating, they feel some pain in the parotid glands. It's not really a full-blown swelling, but they kind of feel like the gland is working, which is a symptom that patients do report. Again, this can give a lot of symptoms from things that are quite common, like arthritis, to cutaneous vasculitis, enlarged lymph nodes, and other things that fortunately are less common, like involvement of the lung or the liver or the kidney. But then again, this gives us a notion that the entire body really is affected. That is a complication that is yet being studied, but it is more and more recognized and replicated, and is a long-term complication of Sjögren, which is an increased risk of lymphoma. This is related to the nature of the disease, so the proliferation of these B cells that they can give rise to lymphoma. And although the patients with Sjögren have a very high risk compared to the general population, I usually say that there's a very high chance that they won't get lymphoma, because it's usually between 5 up to 10 in some serious percent of patients that get this. Of course, this is very high when you compare with the general population, but we are learning more and more about which patients are more prone to develop this, and so we should be more alert and vigilant about this complication. But we can really see this gives us a notion of Sjögren, which is people see, okay, the dryness, the inflammatory parts, the antibodies, and so this more or less is Sjögren's, but it really is much more than this. And this already from 3 years ago, but also very, very well done by Sjögren Europe, gives us the notion of a lot of things that, you know, other people don't see. And this is really, really complex. And we can read from Sjögren's Foundation some patients that complain that I look healthy on the outside, however, my disease is attacking my internal organs and destroying me from the inside out. This is terrible. This terrible disease sets a new normal way of life, which is not normal at all. And these are actual patients' statements. And other phrases such as, I wake up each day hoping a treatment is developed that will allow me to live an active and normal life again. So patients really want to get back to their old lives. And this we can see like in the daily life, the impact that this disease has. So for instance, this patient that says that he or she had lost a passion for dining out. because Sjögren had affected the ability to chew and digest most foods. And we saw last week also to taste food. And so it is much more than just dryness, and below the surface there's really a lot to be taken into account. How do we diagnose this disease? So we have come across the symptoms, but some of these symptoms, or actually most of them, can also be attributed to other causes. And they can be due to other conditions, and people may, there may be another explanation for this, be it drug adverse effects, or other conditions that we need to exclude. But we need to start thinking about Sjögren's when we do have these kinds of symptoms. And also we should take into account that some patients do not have the typical symptoms, but that's more complicated at the time. And then after we interview the patients, we need to actually do the clinical examination and try to observe this oral dryness, try to attest if there's arthritis, if there is, at the moment when the patient's in the clinic, salivary gland swelling, if there are enlarged lymph nodes, if there are features suggesting dysautonomia or skin vasculitis. And so it really is fundamental to do and for the patients to be observed in a setting that is experienced in this disease, so that we can document these clinical features. So, but besides the clinical examination, there are some tests. So these tests are very targeted at demonstrating dryness, or at least reduced function of the salivary and lacrimal glands. This is the Schirmer's test that assesses the tear flow, the salivary flow. Also, we can quantify the corneal lesions and also the lesions of the conjunctiva with the help of the ophthalmologists. Also, blood tests, usually when we suspect this, after we do the clinical examination and a clinical history, there usually needs to be some kind of evidence of immune disturbance, because this really is an immune-mediated disease. And so, and autoantibodies like ANA, which are the anti-nuclear antibodies, which are frequent in the general population. So this does not mean you have Sjögren's. These ones are more specific, but also having these antibodies, it's not the same as having Sjögren's. And this is a very important message. Or other blood tests like rheumatoid factor, raised immunoglobulins, which are the antibodies that we have in our body, or reduction of other factors, other lab tests like the complement. And then there are specific exams, and these are also targeting, so the aim here is to try to assess and attest the inflammation of within the salivary glands. And this is the minor salivary gland lip biopsy, which is still the gold standards to really know and demonstrate. Of course, it has a lot of problems and a lot of limitations. This test, we have to repeat it sometimes, but it is still the gold standard. The salivary gland ultrasound is a technique that is being more and more used, and the scintigraphy is being abandoned, but it does assess the function. It is not specific for Sjögren. So, and other causes can also have positive scintigraphy without the diagnosis being this. And so these are examples of true patients with their consent of what dryness looks like. So, and this really can be that we don't have any saliva at all, different types of features, and also the impact that this has on teeth, for instance, and teeth health. So this is really a major problem. And also another patient that had salivary persistent parotid swelling, and we didn't know if this was just Sjögren's activity or it was lymphoma, and we did a biopsy, and it was indeed a lymphoma, the parotid gland, and after she was treated, she completely solved her swelling. And so Even though this is a feared complication, there is also treatment, and this patient is doing better now. And so the specialized assessment is of course very important. As Anna said, not all medical specialties are acquainted with this disease, and so we really need to try to gather experience and collaborate between rheumatologists, the oral medicine, the ophthalmologist. So this is the Schirmer's test, where we assess the tear flow. This is an example of lesions of the corneal surface, as you can see here. So all these dots are actually little holes in the corneal surface, and this is due to the dry eye. The salivary gland biopsy that we do, and then we can attest the inflammation of the glands. The ultrasound, the scintigraphy, the salivary flow, and the oral assessment. So all of this is very important. And in my center, we do have a multidisciplinary Sjögren clinic that is been going on for now almost 6-7 years. And we have presented these results previously, and this really is a success in terms of approaching patients with this diagnosis or suspicion of the diagnosis, because not all patients have the diagnosis. And so with this, from 2015 to 2020, for instance, all patients with confirmed or suspected Sjögren's had the same evaluation. And so this involves doing all of the assessments. And we can see that over 400 patients were assessed over this time period. Most were referred by other rheumatology colleagues, but also from other specialties. And about half had the final diagnosis of Sjögren. About a third were diagnosed with Sika syndrome of other causes. This can be drugs, diabetes, and often we don't get a real cause for why the patient has the dryness, but it is a complex condition. And then a few patients had other diseases and associated, and also Sjögren's disease. And it's a very complex table, but we can see that for instance, the subjective complaints, so the symptoms, did not differ between patients with Sjögren and another conditions. But what we can see is that, for instance, patients with Sjögren's had much more frequently keratitis, a low Schirmer's test, a positive biopsy, and also a more inflamed ultrasound of the salivary glands. And so we can see that, with this type of assessment and getting more and more experience, we can provide the best in terms of diagnosis, the best care, and also following and treating these patients. And coming then to treatment, so is there treatment or is there a cure for Sjögren's? There is no cure. There are some treatments that aim to improve symptoms and prevent complications. And this couldn't be stressed enough. Sometimes patients are not really bothered by the symptoms anymore, but they really should try to maintain a lot of the important steps to prevent complications. And the treatment is also to improve quality of life. So this is the major, I would say, endpoint, and it's very hard to achieve in this disease. This is, however, a very encouraging era. There are several drugs with positive results in trials. And so hopefully, let's have our fingers crossed to have drugs specifically designed for Sjögren's approved in the near future. But if we can divide by, so the oral part, we heard about it last week, and we can use and recommend saliva substitutes, stimulants, and there's either this can be mechanical, like chewing gum, or a neutral chewing gum, or a chemical like pilocarpine, which is available in Europe, in the US, and some Evaline is also available. And we also do in our center, in some patients, procedure that is cyanoendoscopy, where we go in and look and try to have a look at the salivary gland ducts. Concerning the eye, it's similar. We have artificial tears, either in drops or gel. Topical cyclosporin is also used, and in severe cases, autologous serum. There are other approaches such as lacrimal plugs that we put that can then need to be replaced, and also the impact of pilocarpine here is not that as strong as with the oral part. For the overall symptoms, so most patients are treated with hydroxychloroquine, even though, and unlike other diseases like lupus, it is not as effective as in lupus, but some patients do improve quite significantly. Exercise is crucial to try to manage fatigue, on-demand anti-inflammatories, and other approaches such as mindfulness-based stress reduction, which has had some evidence also in Sjögren. Diet is fundamental, and we are often questioned about this. And the recommendations are a good, healthy diet, Mediterranean diet with non-processed food. This is the best recommendation that we can have for patients. And then some patients do need to have immunosuppressants, either both steroids, which we and patients don't like, but sometimes we need to use steroids. And then other drugs like this one, which are immunosuppressants that are used for other diseases. And for instance, leflunomide recently had a positive trial, and so we're using more and more. In severe cases, rituximab, which is a biologic drug that eliminates B cells and has other risks, can also be used, even though it's not approved for this condition. But as we said, we have new drugs coming, we hope, and so let's have our fingers crossed. And so if you do have been diagnosed or you suspect you may have Sjögren, what should you do? You should talk to your GP, ask him or her to go into a rheumatology consultation or go directly if you have access. And you can consult resources, for instance, like what we have in our webpage in ERN-ReCONNET. And also, and I could not stress this more, the patient association. So Sjögren Europe, here represented by Anna and Coralie, but also Sjögren Portugal, there's Sjögren Spain. So a lot of each country has, and this has been growing and growing due to a huge effort by Sjögren Europe. The Sjögren Foundation in the US has done a lot of work here as well. And also EULAR, and which is the European League of against rheumatic diseases, and also national rheumatology societies can help you find and guide you where should you go and what should you do. And I can finish with a couple of notes. One is, reports from actual patients. This is the current campaign by Sjögren Europe, where patients were asked what are across several countries, what are the most important unmet needs that they see. And so this patient says that only a few patients are lucky enough to have a diagnostic process and quality of medical care. And they mentioned the need for GPs to be better informed of the cluster of symptoms, and also self-care guidelines, not just medications. In Portugal, a patient says that there's a huge lack of understanding regarding these specific needs, and also specialized clinics are rare. We only have one in Lisbon, and also there's the financial and impact of drugs, and also traveling across the country to go to a specific center. The delay in diagnosis again comes referred by other patients And so in the regard that patients see that their physicians look at this as having, low priority in terms of treatment. In Spain, a patient underlines that the necessity to classify this as a disease, not a syndrome, and also collaborate to have more and more data and learn more about this disease. And other notions that you can have access to this on social media and on the website of Sjögren Europe, of unmet needs that are still for patients. And here, patients focus on the lack of having like a proper tool or the drug or other kind of treatment that restores the way they felt previously to being diagnosed and having this condition. And so we are indeed stronger together. And if patients, physicians, the relatives, families, and also coworkers, they all work together, we can be successful. And this is an image of Venus here with her sister when she came back. And she came back and she, in 2017, won a Grand Slam in doubles, female doubles, with her sister. And she reached also a Grand Slam final in singles. And so even with this disease, with some adaptations for sure, and struggling, she was managed to come back stronger. Thank you. And we're now open for questions, I think.
Thank you, Professor Vasco Romao, for this very comprehensive presentation. We already have several questions in the chat as well as in the Q&A box. The very first one that popped in was, can COX-negative muscle fibers be found in muscle biopsy because of Sjögren's without signs of myositis? It's a very specific and technical question.
Yes. So this webinar is called Sjögren's Essentials. So this is a very specific questions. We don't know a lot about Sjögren's myopathy because sometimes there is myositis, but then patients get treated, and so we can't really do the studies. Other times patients have other conditions. They can have Sjögren's and, for instance, dermatomyositis, and have both diseases. I would say that it is hard to attribute muscle changes just to Sjögren without any clinical signs. But again, we don't know many things about this disease yet. We will in the future, I hope.
Hopefully, thank you. Another question is, many patients have tendinopathies. The scientific community usually says it's not related with Sjögren's. How do you explain that rheumatologic inflammatory disease attacks joints and sometimes muscles, but not tendons or ligaments? Mm-hmm.
This is a very important question because and one of the slides wanted to demonstrate this, that sometimes we're focused on inflammation and now the antibodies and all disease activity. Now all of this is fine, but the patient feels very poorly because he or she has for instance, shoulder tendinopathy, shoulder or hip. It is hard to say that it is related or that it is not related to Sjögren. The inflammation that goes on within the joints is completely, and this is true also for instance for RA, it's completely true. It's completely different within the joints, synovitis, and also outside the joints. So it's a different type of inflammation with different mechanisms. This is the first point. The second point is that tendinopathies and extra-articular, periarticular conditions are very common in the general population. But then the thing is, and this we can consider it being related to Sjögren, is that if you're more or less active and you cannot maintain the levels of activity that you could before because of the fatigue, and you start decreasing the overall levels of activity, the tendons and the muscles and the ligaments, they do not have the strength, and they start to have changes. And these are called degenerative changes that then can inflame and give you, symptoms in the shoulder or the hip. And this is very, very common. So usually we say, you can hear that, okay, this is not due to Sjögren, like it is not important. Okay, it is important because that's what the patient is complaining about. But it is important also for clinicians to be aware of this and be able to recognize, what are we talking about? Because the treatment for a tendinopathy, regardless of the cause, is completely different for if the patient has shoulder arthritis. So that's why you need to have a proper clinical assessment. But again, and I think I will say this in every question, we have a lot to go on in understanding some of the complaints of patients.
It's a long road ahead. Another question is, we know that research is progressing, and recently some clinical trials have come back positive and large cohorts will be launched. Very concretely, if these results are confirmed, how soon do you think patients will be offered a targeted treatment available in the market?
So this is concerning the good news. And so the good news is that we have published 2 published trials with 2 different drugs. These are not yet phase 3 trials. So phase 3 is the final phase of a trial. And if the drug is successful then, and very successful, then the company may decide to apply it for this specific condition. We are not there yet, but the results from the phase 2 trials were very encouraging. So encouraging that they moved on to the phase 3 that is currently happening. For instance, in our center, we have one of the phase 3 trials that is ongoing around the world, and we have several patients included. This is good because in these centers, and for instance, in my center, we can offer patients access to other innovative medications. But when will this be available for everyone? This takes time, unfortunately, because it usually takes about 1 to 2 years to get everyone into the trial, and then everyone is followed up for 1 to 2 years, and then they have to analyze the results, publish the results, and then apply for the medication. So it really is a long process. It's not just for this; it's for any drug. That sometimes, even though it's very promising, sometimes they fall along the way. And we just had some examples, for instance, with baricitinib in lupus, where the results were very exciting, but then in the end, they were not that exciting and it didn't move on. I think this is not the case here, especially because there's no treatment for Sjögren.
Exactly.
So I think in about, I don't know, hopefully 5 years. 5 years. 5 to 10 years, we will have these drugs available. And how will they be then used? It will be dependent on how will they be approved for which manifestation, or if it's for everyone. So still probably lots of things to define.
We need to be patient again and again. Okay, another question. Is Sjögren's potentially a dangerous disease? If so, how many patients die from this disease in percentage? So we've seen that 5 to maximum 10% of patients can develop lymphoma. And from that percentage, which percentage of patients really don't make it? Do we have this data available?
If it is potentially dangerous, it is potentially dangerous. But in fact, even for the cases of lymphoma, most cases of lymphoma have a good prognosis compared to non-Sjögren's lymphomas. We don't really understand why, but again, we know that these patients, if they're being followed, we are already vigilant. Maybe that's one of the reasons, but usually they have a good prognosis. But sometimes it's not the lymphoma, but other manifestations that fortunately are rare, but can involve, or more rare, especially if severe, can involve, for instance, the lungs. In very rare cases, very severe central nervous system disease of the brain. But this is, we're getting into the rare manifestations of a disease that is not so common. And so it is potentially dangerous. It needs to be followed up, and we need to prevent severe complications. The truth is, we don't know yet who will develop these more severe complications or not. But we need to be vigilant, because we know which are the patients with a higher risk to go.
So we can say that regular monitoring is key to anticipate, to be vigilant and detect these very rare complications and act on it in due time. Another question here is Sjögren connected with other connective tissue disorders like plantar fibromatosis, for instance?
I would say no. So plantar fibromatosis is a disease it's not very common, but we don't see it in increased rates in patients with Sjögren's. So even though the term is within connective tissue, and plantar fibromatosis, of course, involves the connective tissue, it is not specifically related. I wouldn't say so.
Okay, so is Sjögren most often progressive? Is another question.
What we are realizing now is that there are probably, even though it's a single disease, probably there are different types of disease, or different groups of patients with different kinds of disease. So patients that are stable in terms of new manifestations, they don't have new manifestations, and we have to manage and prevent the complications and manage mostly those three key symptoms. But patients that from the start have systemic complications, and then a third group of patients that will develop them along the way. And so it's not, Anna, remind me, the question was?
If Sjögren is most often progressive.
Progressive, yeah.
Progressive.
So it depends, because, and this happens in these diseases, because it is very heterogeneous. For instance, if a patient has joint disease, we can control it, and it is not very progressive. It can be, but we can control it. But it's really targeted. But some patients do have always very active disease. But it seems that it's not that for everyone it will progress, but for some patients it will have the tendency to remain more active and more difficult to treat. We don't know why. We are identifying which patients are these and why this happens, but that's why we need to follow them almost on a case-by-case basis.
Okay, is exercise intolerance common in Sjögren's patients? It's another question. It's a very good question.
Yeah, yes, it is common, and it was on the fatigue slide. One of them was the post-exertional fatigue, which is again related to some feature of dysautonomia that may be present in this condition. But also it is hard, but also in some patients it is a very good a very good tool to try to improve some of the symptoms. And so when patients find what works for them, they really should stick to that. And it's not a one-size-fits-all prescription for what should I need to do if I have Sjögren's. So that's why you need to see a lot of patients and really try to do the recommendation for each specific patient. It's not that this running is better than yoga or gym is better than swimming, but for some people some things will work better. And what really is important, and this is not just for exercises, is that patients learn to listen and feel what their bodies are asking. And if their bodies are asking for rest, there may be a reason for that. And so we should probably listen.
Okay, another question is, would jaw pain also be related to Sjögren's? Every time I attend my dentist, my jaw sits up, having mouth wide open so long. So jaw pain and Sjögren's.
Mm-hmm. Well, in that event, you know, when the mouth is open for a very long time, may be a specific effect of the muscle contracting after being stretched for so long. But what we do know is that, you know, as a general term of stress, and also the stress that Sjögren implicates, and the stress of going to the doctors all the time, this is a known feature of jaw problems. And so jaw and temporomandibular dysfunction is also common. If it's directly related to Sjögren, when we consider it, you know, is it inflammation of the muscle? Probably not, but it is part of the spectrum of the disease. And if patients have that, so we should, you know, take that into account.
Okay, and a last question. In one of your slides, when you were describing the way diagnosis was done and all the tools that is used by rheumatologists for diagnosis, there was this note on the evidence of autoimmunity. What about seronegative Sjögren's, when we can't find evidence of autoimmunity in blood, and when we have salivary glands, minor salivary glands biopsies that are negative, but most probably false negative? This is a huge challenge, isn't it, to follow up these patients?
Again, this is the Sjögren's essentials. We can have the Sjögren controversies another day, but yeah, of course, there is a bias towards the autoantibodies and the biopsies, and especially the autoantibodies also fluctuate, that's true, but especially the biopsies can be negative because we are, you know, getting one bit of tissue, but maybe if we get the other tissue just next to it, we would get the diagnosis. And so, and that's why criteria and classification criteria are classification criteria. So these are designed to include patients in research studies, and the diagnosis is clinical. At the same time, there's another point, that is, there are certainly other autoantibodies that we don't know about.
Yes.
And so we will discover them in the future. I hope this is happening in, for instance, in rheumatoid arthritis, where seronegative RA is attached to about 20–30% of patients. And now we are learning that a percentage of these are not seronegative, they just have other autoantibodies. And this is probably true also for Sjögren. But finally, I think that we also sometimes need to, you know, conclude that if everything points that it's not Sjögren, we have an alternative cause for this, even if it's you know, difficult to explain. We also have to admit and assume that, you know, the diagnosis might not be this. The treatment might be the same or very similar, especially for the exocrine function. But sometimes, you know, and with the knowledge that we have nowadays, it is hard to make such a diagnosis.
Okay, I think we are on our time. So I think we can say as a conclusion that we need new and better diagnostic tools, and that there's a lot to discover about Sjögren's. So hopefully research on Sjögren's will be speeding up from now on, and we will have better conclusions and better news and in the future. So thank you for your message of hope, which is the main message of Sjögren's Essentials. And hopefully we can bring you back, or someone else, with Sjögren's controversies for a new webinar.
Thank you, Anna, for having me, and thank you all for being there, listening.
Thank you, everyone. Thank you so much for listening.